Hello everyone. So this is the 23rd video on POORI TARAH RATO, and in this we'll discuss about OHAs and their classification. Okay. Basically uh, on the baseline, OHAs are divided into secretagogues and non-secretagogues. So secretagogues are the OHAs which depends on insulin secretion for their action. So they will increase the insulin secretion. The examples are sulfonylureas and maglitinides. Since they increases the insulin secretion, they can lead to hypoglycemia. The other class of drugs are non-secretagogues, which don't depend upon insulin secretion for their mechanism of action. So they don't lead to hypoglycemia. In non-secretagogues, we have insulin sensitizers and others class of drugs. In insulin sensitizers, we have biguanides and thiazolidinediones. So both these classes of drugs improves the insulin sensitization. Okay. Now let us start with secretagogues first. So the first class of drug is sulfonylureas. It acts by inhibiting ATP sensitive potassium channel. Okay. Now we have two generation of sulfonylureas, first generation and second generation. In first generation we have chloropropamide, tolazamide, and tolbutamide. And these have very longer half-life. So they are not used now because they had an increased tendency to cause hypoglycemias. Okay. In second generation, we have glimepiride, gliclazide, and glipizide. They have rapid onset of action and also shorter half-life as compared to first generation sulfonylureas. So they are commonly used now. And out of them, gliclazide is somewhat renal safe. So it can be given up to a GFR of 30, while all other sulfonylureas should not be given below GFR of 60. Okay. The side effects of sulfonylureas is one is hypoglycemia, is a commonly known side effect. Other side effect is weight gain. Okay. Other class of drug is magnetides. It is also a secretagogue, so it can again lead to hypoglycemia. The mechanism of action is similar to sulfonylureas, that is inhibits ATP sensitive potassium channels. The examples are rapaglinide, nataglinide, and metaglinide. The mechanism of action, although is similar to sulfonylureas, but they have very short duration of action. So they have to be taken before meals. Like we generally give rapaglinide 3 times a day and each time before a meal. Okay. And side effect is similar, hypoglycemia. And another one is weight gain. Since these drugs have to be taken thrice daily, so they generally are not commonly used. Biguanides. So in biguanides are the most commonly used OHAs. It is a non-secretagogue, so it doesn't lead to hypoglycemia. It is an insulin sensitizer, so it increases sensitization and further can reverse the diabetes. Okay, so insulin sensitizers are the drugs which can reverse the diabetes at an early stage. Okay, the examples are metformin and fenformin. The mechanism of action is by decrease hepatic glucose production, that is reduces gluconeogenesis. Other than that, it activates ATP dependent protein kinase. Okay, it can lead to modest weight loss. Okay, and then we have side effects. In side effect, we have one is vitamin B12 deficiency. Other than that, it can lead to lactic acidosis, which is more common with fenformin and less common with metformin. And contraindications are GFR less than 30 and any acidosis in the body. So any failure like heart failure, liver failure, kidney failure can lead to acidosis. So all three are contraindication. Liver failure, CHF, and kidney failure or severe hypoxia. Because all these can lead to acidosis. So they are the contraindications for biomarkers. We have another class of drug, thiazolidinediones. They act by PPR gamma agonist. Okay, these are also insulin sensitizers, so they can reverse diabetes. We have another class of drug which is PPR alpha plus gamma agonist. So you have to tell me in the comment section that what is that drug and what it is used for. Okay, the examples are rosiglitazone and pioglitazone. They can lead to weight gain and increase in plasma volume. So they can precipitate heart failure and they can lead to pedal edema. So they are contraindicated in CHF patient or heart disease patient or hepatic insufficiency patients. Okay, and pioglitazone is also seen to be associated with bladder cancer. So FDA contraindicates this drug in patients with increased risk of bladder cancer. Okay. Then we have this wonderful class of drugs which are known as SGLT2 inhibitors. So they got developed as a OHA, but they are now also classified as a cardiac drug because it is given in patient with heart failure with reduced ejection fraction. It acts by increasing renal glucose excretion. Since it increases renal glucose excretion, it also increases renal water excretion through osmotic diuresis. So it leads to weight reduction. It has a diuretic effect, so it decreases BP also, and it is given in heart failure with reduced ejection fraction, and it is cardioprotective. Okay. So, agar the question is asked that what is the first line OHA in general, then it is metformin. But what is the first line OHA in patients with cardiac disease? Then it is SGLT2 inhibitors. Or what is the first line OHA in patient with heart failure? It is SGLT2 inhibitors. Okay. Then examples are dapagliflozin, empagliflozin, and canagliflozin. They are also renal safe, but they should not be given at GFR level of less than 30. Side effects which are commonly asked are: one is UTI, second is euglycemic decay, third is peripheral arterial disease. Okay, but peripheral arterial disease is seen to be more associated with canagliflozin than with EMPA or dapagliflozin. And we have this class of drug which is known as DPP4 inhibitor. So we have incretins in our body. Whenever we have food, incretins released from the GIT goes to the pancreas and increases the secretion of insulin. Okay. So we have GLP1, GIP as incretins, and these incretins are destroyed by DPP4. So if we have a drug which inhibits this DPP4, they will increase the incretin level and further can lead to increase in insulin. Okay. So the examples are vildagliptin, linagliptin, and sexagliptin. All these are cardio neutral and weight neutral. Okay. Out of them, linagliptin is renal safe and it can be given at any GFR level. So it is the only drug which can be given at any GFR level. Otherwise, we have to give insulins to CKD patients. Other than that, side effect of DPP4 inhibitors are pancreatitis. And the important thing is that incretin are usually released whenever we eat something. So that's why DPP4 inhibitors increases the level of incretin and further increases the level of insulin only at postprandial meals level. Okay, so only postprandial insulin levels are increased, so they don't lead to hypoglycemia, and that's why they are not classified under sulfonylureas or under secretagogues per se. Okay, then we have this alpha glucosidase inhibitors. So what they do is कि oligosaccharides जो भी we are eating or we have in our GI tract, they decrease their breakdown to monosaccharides. So examples are acarbose, voglibose, and side effect is कि जब oligosaccharides break down नहीं होंगे monosaccharides में, so they will be there in the stomach and released as diarrhea. So they can lead to diarrhea or bloating. The contraindication is IBD and gastroparesis. And these alpha glycosidase inhibitors again have to be taken pre-meals. So we have to get them thrice daily dosing before every meal. And Another important thing is, since it is decreasing the conversion of oligosaccharide to monosaccharide. So suppose the patient is on alpha glycosidase inhibitor and on insulin as well, and that person is having a hypoglycemia episode, then the treatment here is glucose only. So orally we have to give glucose to the patient. We cannot give sugar, or we cannot give sugar to the patient, okay? Because the patient is on alpha glucosidase inhibitor, the oligosaccharide would not be converted to monosaccharide, okay? So अगर हमने patient को sugar दिया, so it won't be converted to glucose and it won't get absorbed. So we have to give glucose to that patient. Then we have this class of drug which is GLP1 analog. As we have discussed, GLP1 is a incretin, but these drugs are injectables and are taken by a subcutaneous injection, except semaglutide, which is available both in parenteral and oral forms. And semaglutide it is really a hot topic. Semaglutide पर बहुत studies चल रही है recently. One thing is कि it is oral. Second thing is all these GLP1 analogs lead to significant weight loss. So they are also given as an anti-obesity drug. Also, important thing is that they are cardioprotective. Okay. The side effects are pancreatitis and increased risk of medullary thyroid cancer. Then the last class of drug is amylin analog. The example is pramlintide, and they act by decreasing gastric emptying and decreasing the level of glucagon. The side effect is nausea, and this is the only OHA which can be given in type 1 and type 2 diabetes. But the only drawback is that it has a very low efficacy. It reduces the glucose level by only a slight. It leads to only slight decrease in the glucose level or slight decrease in the HbA1c level. Okay. All the best, guys. Just try to remember each and every OHA because it is a very commonly asked question.